What are guidelines versus policies, and how do they clash in the real world? We'd like to address this as what's right versus what's right, coding guidelines versus policies. With the buzz of artificial intelligence solutions incorporating themselves into the digital healthcare landscape, and with the potential of incorporating it in the medical coding world, how do we determine what is right? That is the question that has vexed the validity of medical records from both an administrative and clinical perspective. In order to get our hands around the difference between policies and guidelines, and notice we drop the word coding from guidelines and policies for the moment, as it becomes relevant to define each in its raw form, we first must define a policy and a guideline so that we can better get our hands around what is right. While this may be a word salad or juggling around with syntax, it comes down to how we define what is right, with potential philosophical ramifications. At this point in the discussion, let's omit the terms gold standard, answer key, or primer. A policy or policies are defined as set forth by a group, individual, or institution as a definite course or method of action selected from among alternatives and in light of given conditions to guide and determine present and future decisions. It is also a high-level overall plan embracing the general goals and acceptable procedures, especially of a governmental body. A guideline or guidelines is a rule or set of rules giving guidance on how to behave in a situation, a piece of information that suggests how something should be done or what something should be done. For the healthcare industry, guidelines are produced by the official agencies, as follows: Centers for Medicare and Medicaid Services and the National Center for Health Statistics, two departments within the U.S. federal government's Department of Health and Human Services, provide the following guidelines for coding and reporting using the International Classification of Diseases, 10th revision, clinical modification. So how and where do policies and guidelines collide in the real world of healthcare coding? The number one collision of policies and guidelines is the problem of poor documentation. Poor documentation rears its ugly head as it is directly associated to human input. This is often attributed to repetition and/or workload, or it is attributable to the lack of emphasis with practitioners taking the time to adequately describe the reason for a visit happening due to shortcuts taken. Can we call it laziness? You make that judgment. The problem with this from the health information management perspective is that it leaves the door open to reporting or assigning codes that are not in support of anything written in the encounter. Again, assigning codes that aren't written in the documentation breaks guidelines. If you lead, if you infer, if you imply from the documentation, you breach the guidelines for coding. See the guideline document attached. This is a major denial mechanism, one that providers are focused on, whether they are hospitals, clinics, or practitioners. This focus on clinical documentation improvement assumes that auditors on the payer side have the time to thoroughly review millions of records and that denials for poor documentation are going to happen all the time. The real-world practice never matches up with any of this. The real world has always been that they don't and won't review every single record due to time and manpower. There is evidence in the nomenclature that many records go through the payer process for reimbursement without, and I repeat, without, ever being reviewed. There is simply not enough resources for the system to handle this side of the process completely, so many mistakes in the documentation simply get passed through the payer system without a denial, even though there are mistakes in the provider documentation from the start. Yes, there is software in the industry that automates the auditing process for complete processing and review, such as our own AMI auditor, and that high-volume processing is available with a higher than human accuracy as defined by the degree of precision and recall, but payers are slow to provide these tools, which may be due to the fact that the system would be overloading with denials, which would break an already ratcheted system, which is the provider-payer reimbursement system in its entirety. And because the payer requirements attempt to mask much of this, but are designed to put lots of administrative burdens on the providers to follow constantly changing guidelines, there are sometimes written, but mostly not, policies that are put in place to overlook guideline requirements and emphasize the importance of getting the bill out the door in a timely fashion. Policy rules are put in place to cover up poor documentation. We see this on all types of encounters. However, there is more prevalence of this in the high-volume outpatient areas. We have provided a completely de-identified example as shown in this video. A policy of a provider might be to infer that the patient was going to have a diagnostic radiology procedure, yet no diagnosis was documented in support of that procedure. The fact that presumed comparison studies were dictated but not done because the patient never showed up is just plain wrong. Yet the policy is regardless if there is an encounter in the system, it must be coded and to the highest level of specificity. Infer what you can and hope for the best. Yet this encounter went through to billing and was never picked up in any manner on the payer side, and with that, infer what you will. Unfortunately, and again as stated, we see a preponderance of really bad documentation coming from the source, that is, providers and practitioners, often enabled by the system in which all physicians and providers practice medicine. Focus on the patient, not the paper, or entering information into the EMR. That said, here's another example. We don't have time to waste on documentation. I'm too busy. I'll reconcile my paperwork at the end of my rounds or shift. These are great excuses which we constantly receive this type of feedback from the medical provider community, and because of this, CDI or clinical documentation improvement specialists and/or companies have thrived in this environment of bad documentation. That said, here's another example that opens up the proverbial door of policy versus guideline. What can we critique from this documentation? Well, the practitioner missed the other no pulmonary nodular amyloidosis since he was making the PE versus PNA evaluation as the reason for the procedure. But that is just sloppy and lazy, and for all we know, he couldn't pronounce it correctly if dictated or spell it within the EMR. But, in fact, the only real codable event in this encounter was the CPT procedure 71275, CT angiography of the chest. According to guidelines, there was no diagnosis from this encounter, yet we can safely maintain that the policy for this facility, obviously nameless, is that all encounters must provide a diagnosis. So when, as an example, the policy says make sure all encounters have a diagnosis, that becomes a policy that directly conflicts with guidelines, and we see the insertion of spurious diagnoses to fill in this policy requirement, again, not represented in the guidelines. It should be noted that our software correctly represents guidelines as its baseline, but can be tuned or adjusted to incorporate most policies. To remain compliant, we mark any policy changes represented in the output for the facility or practitioner, so these are tracked in our database for obvious audit reasons. So there you have it, the real-world conflict between policies and guidelines. What is the answer to address poor documentation? CDI specialists? Revenue cycle management professionals? Their role is to maintain policy and provide better reimbursement for the facilities and practitioners. And they aren't really focused on improving patient care, as this paradigm ends up being more focused on the business side, namely payment reimbursement, whether it's maximizing payments or getting bills out the door faster. Too bad, because better documentation improves patient quality of care and communication between those providers affected by their role in the patient care team. Would they indeed follow policies or guidelines? And there is another conundrum in this paradigm. The question bodes well for asking. Why does this happen? Medical training. This is the first and source culprit in the blame game, and you have to ask how this could be one of the sources of the problem. The answer is shockingly a simple one, with deep philosophical hooks, and it goes something like this. Medical training is focused on training physicians, teaching physicians to diagnose and treat patients, and not on being good at documentation, or aspects of administration or the business of medicine, namely medical informatics. We hope this video was informative, revealing, and educational, and we hope you continue to watch our videos and like and subscribe with more great content in the weeks and months to come.